A common misconception is that social workers are only for people who lack resources. The reality is, I think a lot of our patients need support from social work for additional issues. So one example would be a man was in the hospital for alcohol withdrawal. Comes from a wealthy family, has a lot of support. And I was told in rounds that his mother set him up to go to a program. He was all ready to go. Physician felt like everything was set, so no need for social work to get involved. But, I just popped my head in to meet the guy, see what was going on. Told him that, oh, I heard you're going to a rehab program. What? What are you talking about? So I ended up sitting down with the guy, doing some motivational interviewing and some expert interventions, and he wasn't quite yet ready to go commit to a program, but we talked about relapse prevention and made a plan. People are in the hospital because they're in a critical point in their life. And so if they're having trouble coping, we're there to provide that support and kind of figure out what the next steps will be, or, to see family through it and give them that support.
Physicians should not expect us to know everything about insurance. We're not an encyclopedia of insurance knowledge. So I do recall a time when I was on rounds with my team. I work specifically with patients who are awaiting liver transplant. When we got to the bedside, the family was very upset and concerned that they were not going to be able to afford this hospital stay. And the physician turned to me and asked me if I could help get to the bottom of, what they would expect from their hospital bill. I said Medicare does cover 80% of the bill. They had no secondary. I knew they would be responsible for that 20%. I offered to get financial counseling involved. I stated that to the physician. As a case manager, I do know certain things about insurance, but when it comes to a hospital bill and itemized things and knowing their prices, that is not something that case managers know off the top of their heads. That is something that is specific to financial counseling.
When physicians come to us and say, here's a problem, we know you can fix it, and it has to do specifically with a resource, this is when we get into this situation of needing to explain why we are either unable or we think it is inappropriate to provide a resource to a patient in this particular setting. A patient that I was working with that was transferred by medevac for a cancer diagnosis, but in the context of a very serious cardiac issue, and that was what the medevac was for, was brought here and stayed for a very long time. And when he was done with his treatment, the physician said, okay, how are we going to fly him home? And the answer is, we're not going to fly him home. Like, the reason he was flown here is because he had a medical need. Now he's medically stable. And the physician said, well, how are they supposed to get home? We brought them here. So we had to really have a pretty frank discussion about the fact that we don't have that resource. And the patient made it home just fine in his son's car. While it is a good thing for physicians to want to include us in a wide array of discussions, the place where we lose or where we kind of tip over that edge is where then the assumption is, because we can be a part of any discussion means we can fix any problem.
Common misconception among some physicians that discharges just magically happen, and they don't. It takes a lot of work, a lot of effort, and a lot of time and teamwork to put together a discharge. I was in rounds on a Friday morning at 10 a.m. when I was told that this patient was ready to go. So I told the physician what we needed. 2 weeks worth of meds need to go to our pharmacy next door. She needs to leave with all of those in hand, all of her medications. And she needs to be ready, dressed and ready to be out the door no later than 1 p.m. And so I went to check the meds, and at the last minute realized all of the meds weren't there because all of the meds weren't sent. So I had to call medical respite, let them know. They said, well, if she doesn't have all of her meds, then she can't go. So we finally, at the last minute, it was like past the time where she had to leave, called them, begged them to take her, and they said yes. She ended up going, and I found out she left the shelter because the whole day was just too much for her, and we don't know where she went. If the physician would have notified me earlier about the discharge, I would have had a lot more time to follow up on the medications, make sure we had everything that we needed before sending the patient out. I think it really could have helped the patient and made for a smoother transition.
There are many physicians, I would say almost all physicians, think that even on the weekends, patients can be discharged at any time, with any different service, just like they would be during the week. But that is very false. A lot of companies shut down on the weekends. So I can recall one specific time where I was following a service line that is not my own, and I had checked in on a Friday morning at 9 a.m. like we always do, and I said, which discharges should I prepare for today, and which ones do I need to start preparing for the weekend? Went and saw those patients, got their discharge plans in order. It's 3 o'clock, and I get a call from that same physician, and she can go to a skilled nursing facility tomorrow. So I went off to see the patient. I interviewed them, faxed off the referrals, got on the phone to call the admissions director, and of course they had gone for the weekend. And the patient sat in a bed while the ER piled up, and finally the patient discharged on Monday. It was completely unnecessary, and had I known, even at 9 a.m. that same day, I could have definitely gotten that patient out Saturday morning.